Who here takes a sore throat lightly? Does everybody see patients in the clinic with sore throats? Do you all take it lightly, or is it a condition that we should be worried about? We should always be worried about stuff, right? That's what life is all about. You always worry, okay? So say somebody comes with a sore throat, okay? What are you worried about? Are you worried about, sometimes patients can have a strep throat, right? It's a very common condition. Strep throat by itself is not the biggest problem, but strep throat can lead to a lot of problems in the future. So when somebody is coming with strep throat, they're clearly going to come with sore throat, right? They can have a fever. So what criteria are you going to use in order to diagnose strep throat?
The centaur.
Yes, there's a criteria called centaur criteria. And what is the centaur criteria? Tonsillar exudates. Okay. What's another T for?
Tender lymph node.
Yes, tender anterior chain of the cervical lymph nodes. F stands for fever. And lastly is A, which is absence of cough. So you have 4 criteria based on centaur to tell you if the patient most likely got a strep throat. Now, once you suspect somebody is having strep throat, how are you going to diagnose it? You're going to test them, right? Decide if the patient has a higher likelihood of strep throat versus a low likelihood of strep throat based on the number of points they have, right? So if somebody's got 0 to 1, what is it? It's most likely not, right? If somebody's got 2 to 3, then you should test them and treat them, right? If somebody's got all 4, that means it's a high likelihood that the patient most likely does have strep throat. The big question is this. Okay, if the patient is 0 to 1, it's not strep throat most likely, so don't even test them. Forget about it, ask them to move on, right? Now the question is between 2 to 3 versus 4. If it is 4, it's high enough, right? It is high enough that it's super suggestive of strep throat. So do you need to test them first to prove it, or can you just straight away go ahead and treat them?
Test.
The answer globally, what I want you to know is always test first, prove it, and then treat. Okay? That's always going to be your answer. The exception to the rule is if the patient is much sicker, okay, he's got all 4 features but looking much sicker, and you feel like not giving antibiotics initially might be a problem, then you can make an exception, start them on antibiotics first, and still wait for the test result to come back. If the test result is negative, stop the antibiotic. But most of the time, test, prove, treat. Got it? So how are you going to test them? You're going to do a rapid antigen detection test. Okay? It's basically a throat swab. You swab them and you do this test. How long does it take for this test to come back positive or negative? 15 to 20 minutes, right? So 15 to 20 minutes, you should have the result of this test. Right? So rapid antigen detection test is what you're going to do in most of your patients. If this is positive, great, gives you the answer. Right? So always it's going to be your first line test. Right? Now, the problem with this test is sometimes it can be false negative. Right? Your criteria is high, but it's falsely negative because it's a screening test, right? So what do you do in those patients? What's your next test to do? It's going to be a throat culture. You do a throat culture, and the throat culture typically takes how long to come back? At least 2 days, right? So 1 to 2 days before your results come back, right? So typically you always start with RADs first. If that's positive, you got the answer, you start them on treatment. If that's negative and your suspicion is still high, go for your throat culture. But bottom line is always test, prove that they have it, and then they treat. But the board is probably going to go after the point that if you have all 4, your suspicion is so high, they might want you to start treatment first. I think the way to look at it is if the patient looks much sicker and looks much more unstable, then you would start treatment and wait for the results and then stop the treatment if the results comes back negative. But most of the time, if they look like a normal patient coming to the clinic with all the features, test, treat, prove. Now, is waiting for 2 days a problem? Because this patient's got strep throat. If you're going to wait for 2 days, are their symptoms going to get worse? They've actually observed these patients, not really. They have not really worsened like that. Okay, so the symptoms don't get superiorly worse just because you're not treating them for the first 2 days if you had to wait. But if they are worsening, then of course start them on treatment. Now when it comes to treatment, what are we going to treat them with? What is the drug of choice here? You can use amoxicillin or penicillin V, okay, which is oral penicillin. So you can use amoxicillin or penicillin V, and how long would you treat them for? 10 days. It's going to be for 10 days. Typically you will treat them for 10 days. Okay. Now when it comes to strep throat, why is this a problem? Why is treatment of this condition so important? Because so basically you're saying that the strep throat, which is caused by what organism? Group A streptococci, can lead to what condition? It can lead to acute rheumatic fever, and that can lead to rheumatic heart disease, right? And apart from that, it can also cause post-streptococcal glomerulonephritis, right? But because it can cause these conditions is the reason identification of this condition becomes so important. And the boards know that, so you're going to get questions on it. Okay, so when it comes to streptococcal throat infection, what we worry about is a group A streptococcal throat infection. This infection is important because it can cause acute rheumatic fever, right? So when you say acute rheumatic fever, how do you diagnose acute rheumatic fever? Is it based on lab tests or is it based on a criteria? It's based on criteria, right? So this criteria was defined by who? Jones criteria, right? So you got major criteria and you have minor criteria. What are your major criteria? Number one is carditis, right? Number two is arthritis, okay? Number 3 and 4 are going to be skin lesions. When you say skin lesions, it's going to be two types. You're going to have one is skin nodules, and you're going to have a lesion known as erythema marginatum. And lastly, number 5 is going to be synonym chorea. Now when it comes to minor criteria, what are your minor criteria? You have arthralgia, you have fever, you have a prolonged PR interval, elevated ESR and CRP. So basically when it comes to acute rheumatic fever, it is going to be a clinical diagnosis. So somebody gets a sore throat and a streptococcal throat infection, and after that they can develop these symptoms. Why does it first off happen? What does group A streptococcal infection possess that causes all of this? Well, it actually has M protein present within your group A streptococci, right? This M protein is structurally similar to the sarcolemmal membrane protein that's present in the heart, in the joints, in the skin, as well as the brain. So this process of having this attack happen is known as molecular mimicry. So it's really not the group A streptococcal infection doing the damage, but your body is trying to attack the group A streptococcal infection, but it is counter-attacking all the things that resembles it. And that's why you end up with all these symptoms. So now, when it comes to each individual symptom, let's talk about that. When it comes to carditis, is it pericarditis? Is it myocarditis? Is it endocarditis? Does it affect the valves? What does it do? Everything. It affects everything. It's pancarditis. It may be pericarditis, myo, endo, as well as affecting your valves. So that's important for us to know with your carditis. What about arthritis? What is very unique about the arthritis that happened with acute rheumatic fever? Yes, it's always going to be migratory, asymmetric polyarthritis. So it's going to start from one joint, it's going to be red and painful, then it's going to migrate to another joint, so on and so forth. Okay, so that's going to be very important for us to know, this asymmetric migratory arthritis. When it comes to skin nodules, what are you going to get? You're going to get skin nodules in the extensor surface of the arms. Okay, if you look at the arms and the elbow, this area, you're going to have small nodules in the extensor surface of the arms. Now when it comes to erythema marginatum, typically what happens is, this is the person's body. Typically what you would see is red spots that comes up like this. Okay, red spots that will come up like that first, and then you'll get a central clearing. Okay, so you'll get a central clearing, and it's going to start looking like little wheels. And after a point, it's going to start overlapping like this too. Okay, but it's going to affect your proximal part of your chest as well as the proximal part of your limbs. That's going to be your classic erythema marginatum picture that you're going to see with acute rheumatic fever. Okay, what about syndrome chorea? What happens? It's a
Dancing one.
it's a dance move. So basically what they're going to call this is also known as Saint Vitus dance. Okay, that's what it's called. Typically what you say is athetosis is more distal movement. Okay, whereas choreiform movement is more proximal movement. Like if somebody's got Huntington's chorea, they'll have a lot of proximal movement. Right? Athetosis is more distal movement. Whereas here, syndrome chorea is both choreiform and athetotic. So it'll be more proximal and distal movements are going to be affected. Okay? So these are your 5 features that you're going to have when it comes to your major Jones criteria. Now if you look at your minor, right? Okay. So these are your major features that you need to know. So we understood all of this. Let me ask you this now. So when it comes to acute rheumatic fever, how are you going to diagnose them? How many majors do we need? How many minors do we need? You typically need 2 majors. That gives you the answer. Or you can have 1 major plus 2 minor criteria. If you had that, then you can diagnose them. But this alone is not enough. You have to prove that the patients previously had what infection? A group-based streptococcal infection. That is a prerequisite. You have to prove that the patients had this infection before. So what's the best way for you to prove that the patients had a streptococcal infection in the past? Because think about it. When somebody's coming with a sore throat right now, most of the time they don't have acute rheumatic fever right now. It's going to happen sometime down the line, a couple of weeks later, maybe a month later, right? So think about that fact because it's important, right? So when it comes to proving that the patients had this infection maybe a month ago, what's your best test to do? Very good. You're going to do an ASO titer. Okay? This is anti-streptolysin or titer. Is there anything else we can do? You also have another titer which you can call ADB titer. What does ADB stand for? So once you diagnose them with acute rheumatic fever, what is your treatment? Now this point here is probably one of the most important questions for the boards. Okay? So when you have acute rheumatic fever, first question, how long do you treat for? Is it a short time? Is it like 10 days? Is it a month? Is it 2 months? Is it years? It's actually treated in years. Okay? It's treated in years. So I'm going to put it into 3 spectrums. Acute rheumatic fever by itself. Number 2, I'm going to say acute rheumatic fever plus carditis. So your heart is affected, but no involvement of valve. Okay? Number 3, I'm going to say acute rheumatic fever plus carditis plus valve involvement. I'm going from not so bad to worse, right? This is worse, downwards, right? So when you come to acute rheumatic fever, first one, right? You don't have carditis. You do not have valve involvement. How long do you treat for?